Well, good day to everyone joining us, and welcome to today's X-Talks webinar. Today's talk is entitled Chronic Kidney Disease, Breaking Barriers with Cardiovascular and Renal Integration in Clinical Trials. My name is Ryan Muse, and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes, and this presentation includes a Q&A session with our speakers. Now, the webinar is designed to be interactive, and webinars work best when you're involved. So please feel free to submit your questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel, which is on the right-hand side of your screen. And if you require any assistance along the way, you can contact me at any time by sending a message using this same chat panel. At this time, know that all participants are in listen-only mode, and please note that the event will be recorded and made available for streaming on xtalks.com. At this point, I'd like to thank Medpace, who developed the content for this presentation. Medpace, a global full-service clinical contract research organization, offers phase 1 to 4 clinical development services to biotechnology, pharmaceutical, and medical device industries. They accelerate the global development of safe and effective medical therapeutics, leveraging local regulatory and deep therapeutic expertise, including cardiology, nephrology, metabolic disease, oncology, central nervous system, and antiviral and anti-infective sectors. Now I would like to introduce our speakers for today's event. Dr. Ajay Srivastava is a board-certified nephrologist with over 20 years of experience in adult nephrology, treating common to rare kidney conditions, ICU nephrology, and comorbid conditions such as cardiorenal syndrome. Also an interventional nephrologist. He specialized in dialysis vascular access and has held multiple leadership roles, including the Division Chief of Nephrology, Director of Nephrology Fellowship Training, and Medical Director of Dialysis Facilities. Dr. Nicholas Alp, a board-certified interventional cardiologist with over 30 years of research experience, trained in medicine at the Universities of London and Oxford, and obtained his PhD in immunology at Cambridge. He completed a postdoctoral degree at Oxford, where he held senior academic appointments in cardiovascular medicine. Before joining Medpace, he was head of cardiovascular drug development at a global CRO and has authored more than 75 publications. And Heather Lohr has a Bachelor of Arts in Physical Anthropology and has over 17 years of operational experience in the clinical research industry, with 9 years in clinical trial management at Medpace. Ms. Lohr has been both a CTM and a lead clinical research associate on multiple complicated oncology, hematology, cardiovascular, nephrology, and rheumatology studies. But now, without further ado, let's go ahead and hand things over to our first speaker for today. Dr. Ajay Srivastava, you may begin when you're ready.
Ryan, thank you so much. I can speak for the rest of us here when I say that Nick Alp, Heather Lohr, and I are very delighted for this really tremendous opportunity to speak with all of you today regarding this really extremely important topic. And it really is such an honor for me to have this chance to present with both of them. And especially since we've all worked together on ample projects that have given us really just a unique perspective on cardiorenal issues, especially as they pertain to drug development. So let's go ahead and begin by reviewing our objectives from a medical perspective. First, we'll begin with a broad overview of chronic kidney disease and the implications related to comorbid conditions, including and especially cardiovascular disease. From there, we will foray into the historical perspective on the exclusion of the CKD population from clinical trials, and also comment on the considerations and reasons to increase this population for study. This will lead us then to the one-team approach, where we'll discuss the value of integration in clinical trials and specific considerations for the strategy, including those for cardiorenal opportunities. And finally, before we move on to the operational perspectives, we'll review a cardiorenal case study to exemplify how this cross-collaboration will lead to overall clinical trial success. Let's start with some simple but important concepts that I really want you to keep in mind as we progress through the presentation, because they will serve as the backdrop and stimulus toward this important paradigm shift in cardiorenal integration, beginning with the fact that chronic kidney disease is one of today's leading public health problems, which is increasing in both frequency and prevalence, and is certainly a manifestation of the advances in modern day medicine with resultant longevity, but is also a result of continued improved awareness on a global scale. And it's become recognized as a key independent risk factor for several adverse health outcomes, including, and very importantly, cardiovascular disease, which I can promise you we'll be delving into much further as we progress through this presentation. Let's first take a moment to gain some insight with the understanding that a historical view of medicine and clinical trials really helps forge a path forward towards advancement, and at the same time happens to be very interesting and many times quite poignant. And so what I've done here is just kind of pulled out some really interesting points in history as they relate to medicine development and clinical trials. Interestingly enough, when you look at the slide, we don't have a lot of information prior to 1750. All we know is that in 500 BC, we have the first recording of what we now understand as clinical trial. In 1747, James Lind conducted the first randomized clinical trial. And subsequent to that, over 100 years later, Austin Flint first used placebo in an RCT. In early 1900s, the FDA origin can be traced with the Pure Food and Drugs Act, which is really exciting. And of course, almost 40 years later, was the first double-blind comparative trial. Subsequently, just 3 years after that, was the first randomized controlled trial of strep and TB, utilizing systematic enrollment criteria and data collection. Just imagine where they were before that, so that's really key advancement at the time. Really not that far long ago, though, if you think about it. 1962, was the first time drug manufacturers actually required the manufacturers to prove the effectiveness to the FDA before marketing. So that was absolutely a breakthrough when you think of clinical trials, and an important one at that. And really interesting and really central to some of this discussion is the fact that women were actually only allowed to participate in clinical trials in the early 90s. Prior to that, especially dating back to 1977, there weren't any. And so you really couldn't get gender-specific data on clinical trials, which, if you think about it now, with all the advances we made in just the past 20 to 50 years, is rather unnerving. And as we all know, in clinical trial work in industry, GCP is an extremely important document that was just not too long ago published in the late 90s to establish good clinical practice. And interestingly enough, sometimes I look at clinicaltrials.gov, I don't realize that it's well over 20 years old, but absolutely an important tool. Certainly, these are just some of the many concepts that we can look back on, and one has to kind of think about whether or not we're going to see the same type of advancement that we've seen. Perhaps can we motivate ourselves and use this type of discussion to maybe improve things for the CKD population and beyond in this year, 2023, and maybe start seeing and start promoting increased chronic kidney disease in cardiovascular trials. And certainly we're going to be talking about some of the benefits of doing that for both, the sponsor on the industry side and patients at large. Well, I have to say, it all starts by appreciating this amazing work of art. And I do have to say, I know some of our team members are on and they have really got some amazing talent to produce images like this. But I do want to say that the kidneys and the heart do make it easier from a artistic vantage point. And so the physiology also just makes it that much better, that much more interesting. And we're going to talk about some of that right now. as we think about this art from an abstract sense, and this is something I could just take and put a frame around because it's just really beautiful, let's go ahead and just kind of delve into the intricacies of the body's most intelligent organ, the kidney, so that we can fundamentally apply them to concepts that will be ever so important as we move towards the cardiorenal integration. So with that in mind, let's start with the fundamentals towards understanding kidney function, which, GFR is one of the most important concepts with regard to the evaluation and study of kidney disease. And we start with the question, what exactly is GFR? So first and foremost, you can see on the kidney on the left side of the slide here that GFR basically stands for glomerular filtration rate. And it's essentially the summation of all the filtering units of both kidneys, not one, but both kidneys. And so it's an assumed index of functional renal mass because, we can't go in and actually review all of the functional units of the kidneys. We take the function in aggregate of both kidneys. And beyond that, the nephron is the functional and structural unit of the kidney. And each kidney can have easily over 1 million of these microscopic units that work in unison to do a number of important functions, including filtration. The overall filtration rate is approximately, in a patient that does not have really any kidney disease, about 100 to 125 milliliters per minute. And that equates to about 180 liters a day. And that, if you think about it, that's extremely substantial, 180 liters a day. That type of volume is enormous when you think about two organs that are essentially just the size of your fist. That's really amazing. So fundamentally, GFR tells us our kidney's functionality. Now, as we move over to the kidney on the right side of the screen, whenever there's a decline in function, or essentially eGFR, it could be from intrinsic, which means an issue within the tissue or the parenchyma or the ultrastructure of the kidney, or it could be pre-renal, as you see there, such as those that are in shock or volume depleted, or it could be an outflow obstruction by, say, example, a kidney stone. Overall, a decreased GFR is detrimental to our well-being. And those that have a chronic decline in their GFR have chronic kidney disease. And at the end of the day, decreased filtration means increased toxins and a lot of consequent concerns and issues because of it. So how do we define CKD? Well, CKD is basically any disorder that's characterized by alterations in kidney structure and function. The manifestations of which really do depend on the underlying causes, but the beauty is, objectively, we can identify this with tests that include imaging, like ultrasound or CT scans for structural or anatomic causes. We can do urinalyses, urine protein levels, which we'll talk about in a little bit as well. And serum creatinine, which most people in the healthcare field will be no stranger to, which ultimately is used to calculate GFR, and we're going to talk about that more towards the end of the presentation. The damage or decreased kidney function has to have been around for at least 3 months, regardless of the underlying cause. And the primary reason is really being that there should be opportunity to ensure that this is not something that is reversible or acute, and that is basically acute kidney injury as opposed to chronic kidney disease. And certainly in clinical trials, reversibility of decline in GFR is something that's really important as part of our safety considerations. Now, certainly it is possible for acute issues to cause chronic kidney disease over time and after some level of potential recovery. Also, this 3-month or more of time frame allows for objective and rapid identification and classification of CKD, where you actually don't need to know the etiology of the underlying cause. And that concept alone has helped increase the awareness of kidney disease exponentially, which is absolutely key. I can tell you, from personal experience, that years ago, actually it was like my first job at fellowship, many of the patients that would see me for the first time had to be placed on dialysis immediately or in the very near future because of issues with awareness and identification of kidney disease in the small town that I was practicing in. And, it hadn't really made its mark in the town in terms of, that awareness. But over time, things have certainly improved. Now, as we get into staging, the development of staging, or the classification system for CKD, has been profound, absolutely profound. And if you look at if you can see it, if it's large enough on your screen, the bottom left corner, you can see the footnoting for the citations that were used to develop the evidence for this slide. And you can see here that the KDOQI Clinical Practice Guidelines, the very first line at the bottom left side of the screen, dates back to 2002. And so I was in medical school at the time, and certainly we did not have anything that is so structured that we have today. And this really changed the entire paradigm for CKD. I mean, it just changed the entire concept that kidney disease was a uncommon, life-threatening disease that was cared for only by subspecialists like nephrologists, to one that was rather a common condition with a range of severity that could be identified and managed earlier by clinicians. And so, in that regard, earlier identification would mean earlier treatment, and then potentially slowing the progression, the progressive course of CKD, to avoid comorbid disease and ultimately dialysis and other morbid conditions. So you might see the pattern here that much can be said about this mindset and similar application to clinical trials, right? So, overall, the aim is to really just identify and risk stratify patients efficiently with the staging process and this identification process, especially, for those that are most severe, and to initiate treatments early enough and to have a greater effect on slowing down disease progression as it relates to both renal and overall morbidity. Of course, one of the reasons I got into drug development was because of the fact that the types of treatments that are available in the CKD population is extremely limited. And for those of you that are nephrologists or have been working in the nephrology field, will know that a lot of our immunosuppressive medication is repurposed, for wildly different disease processes. We're using the same types of immunosuppression for those diseases. And so there's a huge unmet clinical need for patients with varying disease processes that are causing CKD. Now, what you see here is the GFR ranges, right? So on the left side, the left kidney here, you see the actual stage, right? So stage is dependent on really two variables. Basically the GFR, which you see the commensurate level of GFR on the right, and this is via a estimation formula, and that comes out at milliliters per minute per 1.73 meters squared that you can see on top of the right kidney. And so for each of these are the relevant stages to the left. And then as you move towards the right of the slide, you can see that anywhere from 60 to over 100%, basically, they don't have what we call CKD unless there's other markers of kidney disease. And so as a nephrologist, I would see patients only after really, once the identification and the comfort with the staging process was, had been experienced more often, I would start seeing patients more with a GFR less than 60. So if you have a GFR greater than 60, you really need to have other markers of kidney disease, like maybe blood in the urine or proteinuria. And we're going to talk more about proteinuria in just a moment here, because that is key. And there's two ways to look at it. Primarily, it's albuminuria, which we tend to see more often in the diabetic population in terms of that type of protein being checked. And then in the nephrology offices, we tend to get UPCRs quite often, because albuminuria is primarily focused on diabetic kidney disease, whereas you can have other types of protein release in other types of kidney disease. And that's primarily why in the nephrology office we tend to get UPCRs. But in terms of following diabetic nephropathy, certainly albuminuria or UACRs are absolutely relevant and fine. Now, these GFR ranges also form the core foundation of eligibility requirements in clinical trials, whether it be early phase healthy normal volunteer populations or renal impairment studies, as well as late phase trials. In fact, and unfortunately, we know from historical context that many trials will not include patients with advanced CKD. In fact, up to 75% of clinical trials may exclude patients with CKD, which basically is a GFR less than 60, which, as you will see, is the very population that really would benefit from pharmacotherapy. Now, in looking at the bottom right side of the screen again, and as we discussed just now, protein albumin is a urine marker for kidney disease or damage, and it's also, again, used in staging just to remind us of that as we move on, because that's a key concept that we want to keep in mind, especially as we get to this slide. So as we can see here, that as a GFR drops below 60, right, as you can see from the slide here, which is basically your G2 level or mild decrease, right, drop from 60 down is your stage 2 and worsen, so all the way down to potentially dialysis needing level. As it drops below 60, just 60%, a patient will have a notable increase in a number of different detrimental and comorbid outcomes, including cardiovascular mortality. And you see that's highlighted red here because we are going to focus on that today, but all-cause mortality. And what about CKD progression? So those that have underlying CKD to begin with, as their GFR declines, it actually increases the cycle of morbidity within the CKD, and so could potentially accelerate the progression of that CKD. And certainly that's just from CKD process in general. That doesn't say anything about the underlying disease that caused it in the first place. And then there's acute kidney injury. Acute kidney injury tends to be very hard to study just because of a number of factors. And so that's something that, I think were to come in. In fact, Nick Alp and I have looked at some opportunities in AKI where we did have an integrated or hybrid approach, as we call it now more recently, and would certainly benefit from that type of approach. And certainly the increasing risk for end-stage kidney disease also. And so we have 5 different really important comorbid conditions that are influenced just by a GFR level falling below 60 on a chronic level. And so that's really debilitating and unnerving to know, and certainly is really another reason why these patient populations are important to study, especially again as we see the contribution from cardiovascular disease. Now, as you can see here, so as a GFR drops below 60 is increased risk, but the albuminuria and or proteinuria actually multiplies that risk. Okay, and so it's actually a really key consideration and a notable pathologic process, which is why urine protein is a very important surrogate marker in glomerular nephrology trials, and also because you tend to see a clinical response much faster than you would a response in GFR stability, because that would take years. But we can see changes in protein excretion in the urine within weeks. And so that's what tends to be focused on in clinical trials of glomerular disease. Now, what I just showed you is supported by the KDIGO guidelines. And, this has been the case, if you look at this, these guidelines have been updated since 2013. But I wanted to show you this because this has been a consideration for well over 10 years, and it's an important one that just shows 2 simple variables, right? We're looking at GFR categorization over here on the left, and at the top is an example, albumin excretion in the urine. And so you can see as the GFR falls, right, as I just showed you on the last slide, which was a little bit more artistic than this slide, I would say, just to give my team more credit there. And as the proteinuria gets worsened on the right, you can see that in this beautiful heat map here, which really looked at relative risk and chances for those poor outcomes, shows you that as each of these items get worse, and you start falling into the red zone, which is a notable increase in these outcomes that I just showed you, especially cardiovascular mortality, and that's extremely important. So, as such, this next slide here shows a number of debilitating comorbid conditions associated with CKD. And there you see in red, very importantly, the two most common being cardiovascular disease and infection. There's no getting around that. And of course, cardiovascular disease in the setting will be the main focus for the remainder of the presentation, but it goes far beyond the presentation. Cardiovascular disease is here to stay in chronic kidney disease, and it really is an important component when we look at this patient population, because especially as technology and medicine improves, medications improve, disease-altering therapeutics become more plentiful. You're going to find that as patients live longer with more longevity, certainly some of these processes are going to increase significantly. Complications can arise not just from the underlying processes themselves, but they can also be from adverse effects of the interventions that are utilized to manage or prevent the disease or its comorbidities. Each of these areas offer a number of opportunities for study and intervention, and I could name a few of these right here, looking at this, where Nick Alf and I and Heather, Laura, and I have worked together on these patient populations, especially dialysis and those related to cardiovascular disease. And Heather and I are working on studies involving secondary hyperparathyroidism, anemia. Certainly, we would love to participate in studies on volume overload, because that is a key component of chronic kidney disease. One of the things that's really important on this slide too is frailty, or when we look at impaired physical ability, because that is something that's really increased in the dialysis population. One of the things that we're going to talk about later is a article that we helped publish not too long ago, which we're going to talk about, and is something that really spoke to the integration of cardiovascular and renal services together. But that really involves, metabolic acidosis and electrolyte imbalance, and all of those things are key considerations. One of the things that doesn't get talked about a lot, but is highly underrated, but really enormously important as consideration, is the longevity of the CKD patient, ESRD patient, as it relates to malnutrition. Malnutrition is key and huge, especially in the end-stage kidney disease population, because those patients lose grams of protein with each dialysis treatment. And prior to that, they were losing, potentially, depending on the disease process, lots of protein in the urine. And as we know, these are precursors to larger components of nutrition. And so we don't want to be losing protein anywhere, because we need it for building muscle, amongst other things as well. And so really important concepts here, especially as it relates to cardiovascular disease. Now, speaking of which, as we do foray into cardiovascular disease, I want to be sure that we're all on the common ground when we discuss this terminology. And so when we refer to cardiovascular disease, we're referring to 4 different categorizations. We look at cerebrovascular disease, which can include strokes, also known as CVAs or TIAs. We're looking at coronary heart disease, which includes heart attacks or myocardial infarction, angina pectoris, which is basically, chest pain, heart failure for sure, and coronary death. We're looking at peripheral arterial disease, such as intermittent claudication, and also development of aortic atherosclerosis and aneurysms, whether they be thoracic or abdominal. So these distinctions are also very important when we're looking at individual manifestations in clinical trials as well, because we have to really consider this compendium either separately or together in aggregate when we think about cardiovascular outcomes in the CKD population. Speaking of which, perfect timing. Let's talk a little bit about some very important and really key concepts as they relate to cardiovascular disease and CKD. First and foremost, cardiovascular disease is the leading cause of death worldwide, no matter what, the leading cause of death worldwide. It's a global killer, absolutely global killer. That has not changed in the last several years. This is even more so for those with CKD, as the prevalence and mortality due to cardiovascular disease is much higher in the chronic disease population. In fact, it can be upwards of 30 times higher in prevalence in those with chronic kidney disease, and that's huge. Also, we see a higher chance of 3-vessel coronary artery disease in those with CKD, and over half of all heart failure patients have moderate or severe CKD. And just as notable and really interesting, but also disturbing, is the fact that a patient with chronic kidney disease is more likely to die from cardiovascular disease than ever having progressed to getting on dialysis. Okay, that's really something to think about. It's substantial, because dialysis is a life-saving therapy. There's never going to be a patient that would be happy with being on dialysis. However, it is a life-saving therapy that was not as prevalent in the 1960s, 70s, and 80s. And so now we have a system to treat these patients, but many of them don't make it to end-stage kidney disease or end-stage renal disease to ever get on dialysis. And that is something that really needs to be discussed and looked into further in clinical trials. Now, certainly, both the prevention and treatment of cardiovascular disease are major considerations in the management of those with CKD as well. However, it's really clear that traditional risk factors for cardiovascular disease in the general population are just not enough to represent the notable increase in cardiovascular mortality that we see in CKD and end-stage kidney disease patients, right? And so end-stage kidney disease, again, when your GFR drops below 15% and you're needing dialysis or kidney transplant, we call those patients end-stage kidney disease. And even after you've gotten a transplant, kidney transplant, they would still refer to that patient as having end-stage kidney disease because they required a transplant. They don't have their, they may still have their native kidneys, but they have received a transplant subsequently because of ESKD. So getting back to our traditional risk factors, some of these are modifiable, most of which, unfortunately, age is not, but I know many of us wish we could. But things like dyslipidemia and smoking and diabetic control, potentially, and also potentially hypertension, obesity, and metabolic syndrome. Interestingly enough, age tends to be the strongest predictor of cardiovascular risk in any risk equation. Now, very importantly, are the added risk factors that we see on the right side of this slide in the CKD population, such as, again, top of the list, albuminuria, huge, malnutrition, comorbid distinction that I made just not too long ago, anemia, mineral metabolic disorders. All 4 of those items were just discussed a couple of slides ago. Key comorbid conditions that occur in the CKD population also are CKD-related risk factors for the development of heart disease. It's huge. It's all tied together. We also know that inflammation is increased in this population. You may or may not have seen some clinical trials that have involved IL interleukin inhibitors for treatment in patients that have higher levels of potentially hsCRP, which would indicate a higher inflammatory state. That's a very novel way of treating this patient population because they have an increased risk for inflammation. It's very similar to giving a low dose of aspirin as a preventative measure. It's really interesting. Now, all of these risk factors can be compounded in the CKD patient, as they are also susceptible to many more of them. And so, therefore, regardless of the underlying disease processes causing CKD, we do see common themes with the CKD-related risk factors that also allow, in addition to the original disease, additional opportunities, again, for study and the prevention management as they relate to these risk factors. So achieving efficacy in multiple targets can improve overall morbidity and mortality rates in this population. And certainly, I can tell you, in the dialysis population, the dialysis patient, we always look at multiple targets in order to prevent cardiac sudden death, which actually is the most common cause of death in the dialysis patient. And generally, the day after the long weekend, for a Monday, Wednesday, Friday patient, it's Sunday morning. And for the Tuesday, Thursday, Saturday patient, it's Monday morning. That's when you tend to see the largest occurrences of death in those patient populations. So I also want to talk a little bit about minimal metabolism. It might seem like an ambiguous term, but it occurs significantly and very quietly. That's the other thing too. A lot of these things are silent markers and silent processes. And so as CKD progresses, in this case, since the kidneys are also responsible for many things, but also bone health and calcium phosphorus homeostasis, in that setting, there tends to be resorption of bone as kidney function declines, and especially as it gets below 60%. 60%, 60 is that magic number that I talked about earlier. And we call that metastatic calcification. When we think of metastases, we think of cancer. But calcium can metastasize too because of the bone resorption. So you end up getting, CKD patients end up getting more brittle bones, especially in the dialysis patient, and they're more prone for hip fracture, which sets them up for at least a 60 or 70% mortality rate once they get admitted to the hospital. So it's a key concept. And so this calcium can deposit in areas such as arteries, which leads to a different type of plaque formation per se. Oh, I can't wait to hear this. So I'm going to go ahead and hand it over to my really esteemed colleague and friend, Dr. Alp. He's going to be giving us the cardiologist perspective. All yours, Nick.
Oh, thanks, Ajay. And it's a pleasure to share the stage with you today to celebrate our work together over the last several years in our cardio-renal integration approach here at Medpace. I really appreciate all the attention to detail and data that you bring to our studies that we do together, your focus on patient safety, and your medical leadership that's so important for the trials that we've successfully run together. So thanks for inviting me to be part of this. I want to share, just 5 key ideas with the audience today. And it really starts with this central idea that the heart and the kidneys, they sink and swim together. And it all happens through an intricate conversation of endocrine interactions between these two organs. Heart and kidney, they're not just pumps and filters. It's a finely balanced, tuned endocrine system aiming to preserve fluid balance and chemical homeostasis. And this is after millions of years of mammalian and human evolution. Adaptations have occurred to preserve tissue perfusion and blood volume under selection pressures that in fact were not present today. But in the past, the selection pressures were major trauma, hemorrhage, and sepsis. And so we live today as modern humans with the result of this finely balanced system that is now having to deal with a maladaptive phenotypical context. Because we progressed from natural selection to modern urbanized civilization, we're exposing ourselves to urbanization, industrialized agriculture and food production methods, and pollution. And these are underlying many of the chronic illnesses that you've just been talking about. And so the second idea really is to emphasize that so many of the common conditions of aging and degeneration that we experience around the world today affect both the heart and the kidneys simultaneously. And I'm talking about conditions like type 2 diabetes, 20 to 30% of the industrialized population, hypertension, maybe up to 40% of industrialized populations, and atherosclerosis, of course, which is such an important consideration for us. So these three processes have direct impacts on both the heart and the kidneys. And then once one organ begins to be damaged, it directly affects the other. And I'll say a few more words about that momentarily. In my years as an academic clinician, I noticed in the early years that cardiologists and nephrologists worked largely independently, often in different parts of the hospital. They recognized hearts and kidneys, but there wasn't a lot of integration or crosstalk between them. But in recent years, I think there's a trend, a development for cardiorenal specialists, doctors and researchers who truly seek to understand the relationship and the balance between hearts and kidneys, particularly when one or both organs begins to come under stress and strain. And I think that's a good thing. We're going in the right direction. I think there's a lot more work to do. And these cardiorenal specialists are what we need as we take care with clinical practice and the care with therapeutics, because many of the drugs that are well established and newer ones that have recently been developed have to be thought carefully in patients with both heart and kidney dysfunction. And then my final idea is really that patients with CKD are in desperate need of further drug development. And drug development industry itself needs patients with CKD. We need to spend more attention on including patients with CKD in our trials across all drug categories to make sure we understand the risk and benefits within those drug development pathways. So I'd like to spend a few moments describing cardiorenal syndrome and what does it actually mean at a mechanistic level. And I have to thank Ajay for the elegant work and publication you created a few years ago describing cardiorenal syndrome. This is an idea that has really developed over the last 15 years. Societies have put forward the idea of 5 types of cardiorenal syndrome. At the top of this figure, you can see cardiorenal syndrome type 2. That's the most common form, if you like. This is chronic cardiac dysfunction, heart failure, atherosclerosis, or hypertensive heart disease that directly leads to renal injury. So the initiator is damage to the heart, which then provokes injury and impacts on the kidneys. CRS type 2 is the chronic form of the condition. CRS type 1 would be the acute form of cardiac decompensation. For example, acute myocardial infarction with cardiogenic shock leads to tissue hypoperfusion and direct acute kidney injury. But CRS type 2 is more common, and that's the top half of the cycle. In the reverse direction is cardiorenal syndrome type 3 acute or type 4 chronic, where chronic kidney disease begins to affect cardiac function insidiously over months or years. And you can also appreciate that because of the interaction between those two organs, once the process begins, it's very easy for a spiral to start and continue. And that really should be a focus of future drug development programs in clinical research. And here in the boxes are a few key points about the kinds of mechanisms that are at play here. And partly it's hemodynamic, to do with tissue perfusion and venous congestion. But importantly, a great deal of the mechanism is driven by non-hemodynamic factors: neurohormonal activation, inflammation and fibrosis, oxidative stress, driving progression from heart to kidneys, and in the other direction, activation of the renin-angiotensin, aldosterone system, toxins, electrolyte disturbance, and acidemia. So once that cycle begins, we have to be aware of it. We have to be aware of the fragility of these patients, but also conscious of how important it is to include patients and participants with cardiorenal syndrome in our clinical trials, so we can really appreciate how the drugs affect these patients and how the patients respond to our new drugs in development. So historically, as Ajay has said, many of these kinds of populations were actively excluded from participation in our clinical trials, and we have a lack of understanding and data on them. But in recent years, we're starting to see more focus on including patients with progressive CKD in our clinical research. And Ajay, perhaps you'd like to describe some examples of that.
Thank you, Nick. That was fantastic. Appreciate that overview. And I would absolutely love to. This actually is really heartening to see. It's really wonderful, and this is basically a few trials that I put on here that really addresses the cardiorenal concept that we're talking about, especially when it comes to integration. And this is basically just a handful of relevant trials in the last 2 years, dating back to 2021. Let's just go around the circle here and talk about these just for a second. Baxdrostat is an aldose synthase inhibitor, and we're going to talk about this a little bit more because this is sort of a little near and dear to our hearts here with regard to Baxdrostat, and you'll see why in just a few slides here. But Nick and I were involved in a study and with our sponsor regarding treatment and treatment-resistant hypertension versus standard of. We were looking at standard of care plus the ASI, the aldose synthase inhibitor, against placebo, and these were patients that were on a maximal 3 drugs, one of which had to be a diuretic, but still had uncontrolled blood pressure. And this study for sure showed a substantial decrease in blood pressure. There were no discontinuations due to potassium elevation, because certainly considered and we're concerned with were potassium, because even though they are not MRAs, they work by blocking aldosterone to the receptor, and so this was a similar concept in terms of safety. And this study permitted patients that had a GFR down to 45. Again, that puts us at stage 3 CKD, right? And so that's pretty notable for a phase 2 trial and treatment-resistant hypertension to have this patient population included just by historical means. But we also tend to see, again, because of worsening volume overload, we tend to see more uncontrolled or treatment-resistant hypertension in the CKD population. Etelcalcetide is a calcium mimetic that is used in patients with hypothyroidism. And what ends up happening is, and again, in the dialysis patient population, kidneys allow conversion of inactive to active vitamin D, which allows us all. Without it, we would not be able to absorb calcium from our gut. But since this is diminished in the dialysis population, and also not to mention the other issues with dialysis treatments, the parathyroid hormone tends to increase because the body senses that there's not enough calcium in the blood, and also the rise in phosphorus level tends to bind the calcium levels. And so what ends up happening is that the parathyroid hormone bonds to the calcium, and also causes a further drop in the calcium level. So the body releases more parathyroid hormone, and you get substantial bone resorption and thinning of the bones in the dialysis patients. And you also get metastatic calcification. And here we see that this drug, aside from what it does to reduce the parathyroid hormone, also causes reduction in left ventricular mass index as well as LVH progression. And that's key because in this patient population, LVH can be used as a surrogate marker for sudden cardiac death. And upwards of 80% of patients that have been on dialysis for a few years will have significant LVH. Finerenone is a new class of MRA, which showed notable relative risk reductions in composite cardiovascular and renal endpoints, hospitalizations for heart failure, reduction in new onset atrial fibrillation or arrhythmia, renal complications from both cardiovascular and renal points of view. So this was key, especially since there's another drug that works on the RAS inhibition pathway, but just a little bit different than baxdrostat. Chlorthalidone has been around since 1960. It has been approved by the FDA, which was a lot younger back then, in 1960. It's been around a long time. And we're just now seeing these results in the past couple of years. It's much more potent than your usual hydrochlorothiazide, and it has a longer lasting action than hydrochlorothiazide. And it has shown very recently that with 24-hour ambulatory monitoring, a notable decrease in systolic blood pressure as well as office pressures. And interestingly enough, paroxysmally, a decrease in albuminuria. Paradoxically, it's really impressive, and has a very favorable side effect profile. This is a really good drug for that patient population. SGLT2s, also now we're seeing much more in the renal population, risk reduction with or without CKD, the composite renal endpoints, as well as heart failure and slow decline in GFR. Going to get into our one-team approach here, and then very soon we're going to hear from Heather about the operational vantage point with a one-team approach as well. So we're looking at it from an operational perspective as well as medical monitoring perspective, where we're integrating cardiovascular and renal teams. Part of that is use of the central lab, right? A very key component here. And again, we do have a central lab service here. We have central lab, our MRL, which is a very key component, and something that we have, as nephrologists and other clinicians, have helped evolve processes because of the patient populations we've seen, and try to streamline, but also add efficiency and innovation, such as 24-hour urine collections as part of endpoint, basically protection, because as you know, 24-hour collections are used for endpoints in terms of proteinuria, which we talked about earlier is very important, surrogate endpoint. And so we do now have mitigation strategies to identify 24-hour collections that have been done inappropriately, and that goes through our lab services. And so we get those alerts for inappropriate collections just as fast, if not sooner, than actual lab results. And that's been a huge breakthrough for us at Medpace. And we've helped standardize some of this methodology. The validation and standardization of biomarkers is key, as newer opportunities and biomarkers are being discovered. And having this continued evolution of processes is key, because collaboration and innovation has to happen in an integrated process. Here, I love the fact that I can get a hold of somebody within minutes, and that's what's important. Also, let's take a look at creatinine, right? I mean, concepts have changed over the years. Creatinine is not a great measure of kidney function. That's why we tend to look at GFR. You can see here that a value of serum creatinine 1.2 means something different for each of these individuals by age and gender and race. However, the ASN task force did away with race-based measures in 2021. They sent out a notice to the public and to the medical community that that is being removed. And so really now the only difference is age and gender that are being used as variables for this equation. And that is to make sure and ensure that the African-American population is not being missed with regard to chronic kidney disease because of the way those calculations were made before. So you can see here that if we leave gender and age, these patients have very different staging of CKD, but it's also because the formula takes into account that we lose a certain number of nephrons every year, unfortunately, after the age of 30. Visual analytics, again, something that I cannot emphasize enough, and something that we're very proud of as well in terms of optimizing integrated processes, especially when you have lab-heavy studies like the study that I'm going to talk about in just a moment here. But very key in making sure that we're not missing safety signals. Heather, myself, Nick, we've been all very much involved with visual analytics for our safety reviews, and they're absolutely key in making sure everything is cross-talking in a team-based method. This is our Baxter-Stat trial that I talked about earlier that was published just a few months ago. And what you see here on the screen are demographic visuals from that study. And this study was very inclusive of races that were, potentially, especially African-American race, which tends to have high pathology in hypertension. And so the study did a very good job of being inclusive for populations that would be representative. And we see here also a great distribution in gender. Plot, we see that, upwards of 75th percentile of patients were older than the age of 60. So that is very notable, but you can tell very quickly from using visual analytics the representation, the patient population, and this is just demographics. These are very important for safety as well. And here, this is our last slide before we hand it over to Heather. But this just basically shows, how this study was successful. And it was very key to have this integrated approach with optimal communication, integration of various functional areas, utilizing visual analytics, and making sure that we had not only global reach for other studies, and when the study was done in the US, but that we covered weekends. I mean, we were fielding lab alerts on the weekends and the holidays, and that was key, especially when we had a patient that had high potassium levels. And as Heather will tell you, we have utilized maximally, operational expertise as well in each of these areas. We have those experts, and all of those people make a huge difference. And again, these successes start with these collaborations. And I know from my own perspective, having close collaboration with people like Heather on operations, who I've really enjoyed working with, is really required for success. And that integration of medical and operational perspectives are key to successful trials, and many different ways, including team training and site identification, regulatory aspects, and patient recruitment, retention activities. And so I'm going to go ahead and pass it on to Heather at this point in time, who's really going to elucidate some of this for us.
Thank you, Ajay. I'll be discussing from an operational perspective some considerations for enrolling and managing CKD and CVD patients and maintaining data integrity on studies in this patient population. So as Ajay and Nick emphasized during their presentation, CKD and CVD patients often have many comorbidities and can be a very difficult population to manage. This is why it is critical for the medical and operational teams to engage with investigators at an early stage in protocol development to ensure that the study design can be implemented successfully in this population. It is important to understand how these patients present at the site and how they are currently being managed, what standard of care is currently being utilized, how it's administered and accessed, other concomitant medications these patients are taking, what equipment and infrastructure may be needed at the site, and its accessibility to site personnel and the patients. The investigators will be able to provide this critical insight and confirm whether or not the study design is feasible and what limitations may need to be overcome. These valuable conversations not only provide necessary information for feasibility and proper study setup, they also help establish a foundation of trust, resulting in effective communication that will be necessary throughout the trial to ensure proper patient management. To successfully enroll a study with CKD and CVD patients, we found that it's important to take a patient-centric approach, provide practical, creative, and flexible solutions to meet the needs of each patient, such as allowing remote consent and remote visits, or even direct-to-patient shipping of IP. The individual needs of each patient will vary, so it's important to have plans in place and be prepared. Strategically plan a positive patient experience to reduce patient and caregiver disruption. Allow patients to continue on certain medications if it's not contraindicated. Limit the number of procedures if the data is not required for your endpoints. There is no reason to put unnecessary barriers in place. support sites and patients to maintain compliance to the protocol. As an example, we found that in order to ensure adequate 24-hour urine samples are collected, it's imperative that both sites and patients are provided with the proper supplies and clear, concise instructions. Also, reducing patient burden by allowing a specialized courier service to pick up the urine sample and ship it to the site for processing, to limit the need for home health visits or making the patient travel to the site to drop off the sample. And tailor assessments to minimize patient discomfort. Are fasting blood draws really necessary at each visit? When considering dialysis patients, can a blood sample be taken from a patient's dialysis access, or must it be a separate venipuncture? Consider timing of study procedures, for example, allowing certain assessments to occur when the patient is receiving their dialysis treatment to shorten the length of their stay in the clinic. While you're at it, provide them with a study-branded blanket so they can be comfortable during their treatment. Taking this patient-centric approach will help you to earn the trust of the patients and make it more likely that they'll be compliant and continue in the study, which will ultimately lead to obtaining the data necessary to progress life-saving therapeutics for CKD and CVD patients. In conducting a cardiorenal trial, sites will typically start out with known patients, but this pool will shrink when taking into consideration perhaps competing trials, the patient being hesitant to change their current therapy, or maybe they don't meet the eligibility criteria. This can be mitigated by facilitating effective communication between investigators and medical monitors with close involvement of the operational team. Proper communication and proactive patient management ensures not only the right patients are enrolled, but that they are able to continue in the study. As an example, we worked on a dialysis study recently that required dose modifications based on certain lab parameters. As you know, dialysis patients have many cardiovascular comorbidities, and this process was very complex. It required close collaboration between the sites, medical monitors, and ClinOps to ensure the dose adjustments were performed correctly so the patients could remain in the study. And perhaps nowhere is it more important to have cross-functional collaboration than in the setup of a study. The medical monitors, operational leads with the central lab, data management and safety all need to contribute to the proper setup of study systems and bring their own unique expertise to the discussion to protect the study endpoints. As an example, when setting up lab services in a CKD population, you cannot use reference ranges from a normal healthy population, or there will be constant erroneous alerts. For example, eGFR, which is expected to be low in all CKD patients. If an investigator receives too many erroneous alerts, they will have alarm fatigue and they'll miss the ones that matter. It is also critical that relevant lab and safety alerts are received not only by the investigators, but also the medical monitors, clinical leads, and CRAs to ensure effective communication and proactive patient management. And that concludes my portion of the presentation. Thank you everyone for your time, and I will hand it back over to Ryan. Thank you.
Well, thank you and everyone for this very insightful presentation. Due to the time, I think we'll wrap up here. I'd like to direct the audience's attention towards the handouts module within the GoToWebinar control panel, where you'll find some additional documentation to download for some further reading. I want to thank everyone for participating in the webinar with questions for our speakers. The team at Medpace will follow up with you, or if you have further questions, you can direct them to the email address that's up on the screen. I also want to let you know that you'll be receiving a follow-up email from XTalks with access to the recorded archive for this event. A survey window will be popping up on your screen as you exit, and your participation is appreciated as it helps us to improve our webinars. Now, I've also sent you a link in the chat box, and with this link, you'll be able to view the recording of this event on this page, and you can also share this link with your colleagues when they register for the recording here as well. So I encourage you to do that. Now, please join me once more in thanking our speakers for their wonderful time here today. We hope you all found the webinar informative. Have a great day, everyone, and thank you for coming.